Leiomyomas are localized, benign, smooth muscle tumors of the uterus. They are hormonally responsive and therefore become bigger and smaller corresponding to the menstrual cycle. Leiomyomas, or fibroids, are found in 25 to 33% of reproductive age women and in up to 50% of black women. They are almost always multiple. They are the most common indication for a hysterectomy. There are several locations of leiomyomas in relation to the uterus. Submucous will be just below the endometrium. They'll tend to bleed, and they are also most likely to interfere with fertility. Subserous are just below the serosa/peritoneum, and the intramural are within the wall. So descending from endometrium, closest to the interior of the uterus, are the submucous. Then as we proceed outward is intramural, and further out is subserous. The submucous leiomyomas can become pedunculated and can emerge from the cervix into the vagina. Cervical fibroids are more rare but can pose a serious complication to a pregnancy in that they can block the cervical os. In addition, with increased growth of a fibroid, it can become parasitic, deriving its blood supply from an organ to which it becomes attached. It is exceedingly rare that a leiomyoma will progress to a malignancy. If it does, it is classified as a leiomyosarcoma. Fibroids will present with a distinct set of symptoms. In greater than 50% of cases, they will be asymptomatic. In cases in which they become symptomatic, the most common presentation will be bleeding. 1/3 of cases will present with bleeding. Bleeding is usually characterized by menorrhagia, caused by an abnormal blood supply, pressure ulceration, and abnormal endometrial covering. Anemia is found in some cases, but not others. Further, pain can be associated with this. There can be secondary dysmenorrhea as well as pelvic pressure. And further, infertility can be a presenting symptom. Submucosal and intramural leiomyomas are more likely to result in menorrhagia. With greatly increased size and misdiagnosis or fibroids going undiagnosed, pelvic pressure can progress to pressure on the ureters, leading to hydroureter and hydronephrosis. Diagnosis is going to rely heavily on physical exam. Bimanual pelvic and abdominal exams. Fibroids are going to feel smooth, firm, and will usually be midline. Sonography can be used to visualize. There will be an acoustic shadowing process that will appear. Other imaging sources can also identify it. Further testing, including a PAP, an endocervical curettage, and potentially dilation curettage, can be done to rule out malignancies or other diagnoses. A CBC can be done to check for iron deficiency anemia that may occur from blood loss. No treatment is typically indicated for most women with fibroids, as this hormonally sensitive tumor will likely shrink with menopause. As such, reassurance and observation are going to be the best helpers most times. You can prescribe oral contraceptives as well as NSAIDs. Myomectomy, if a woman is hoping to retain fertility. A complete cure will be obtained via hysterectomy. Further, to reduce size, in women who wish to retain fertility or who are hoping to shrink the size of these fibroids prior to a surgical intervention is going to be gonadotropin releasing hormone analogs to suppress the cyclic hormone. These will reduce fibroid size as well as blood loss. Danazol is another drug that can be used to reduce the release of endogenous estrogen. Pregnancy is typically uncomplicated by fibroids. However, location will influence and can cause malpositioning of the fetus. Bed rest and narcotics are indicated for pain with red degeneration. Carneus, or red degeneration, is changes of the leiomyoma due to rapid growth, where through rapid growth it outstrips its blood supply and therefore it becomes necrotic. About 1/3 of fibroids recur following a myomectomy. Uterine artery embolization is another option for reduction of fibroids. It's minimally invasive. Clinician will use a slender, flexible tube, a catheter, to inject small particles into the uterine arteries, which supply blood to the uterus. The goal is to block tiny vessels that lead to the fibroids, therefore starving the fibroids and causing them to necrose. Uterine fibroids are the most common solid pelvic tumors in women. On postmortem examination, fibroids can be detected in as many as 80% of women. Most fibroids are asymptomatic and do not require treatment. Fibroids may grow or become symptomatic in pregnancy due to hemorrhagic changes associated with rapid growth, known as red or carneous degeneration. Uncommonly, fibroids can be located below the fetus, in the lower uterine segment or cervix, causing a soft tissue dystocia, necessitating delivery by C-section. The major symptom associated with myomas is menorrhagia. This is thought to be secondary to an increase in uterine cavity size that leads to greater surface area for endometrial sloughing and/or the obstructive effect on uterine vasculature that leads to endometrial venule ectasia and proximal congestion in the myometrium/endometrium, resulting in hypermenorrhea. Other relatively frequent symptoms include pain and pressure symptoms related to the size of the tumors filling the pelvic cavity, as well as causing pressure against the bladder, bowel, and pelvic floor.